So good evening and welcome to our mental health and BAME community webinar. So the aim of this session is to discuss issues surrounding mental health and while the BAME community can be more disproportionately affected. So if you are from a Black, Asian or minority ethnic background, you may experience different rates of mental illness than the white population. So things like fear, stigma and lack of culturally sensitive treatment can act as barriers to accessing mental health care for people from these backgrounds. The good news though is that there are options available to help you overcome these barriers and also to support you getting the help that you need. So if you have problems with your support or treatment, there are also ways to deal with this. So I'd like to introduce you to our speakers today. I'll introduce myself first. My name is Siobhan Cranjanasel and I am here as part of ISCRE, which is the Ipswich and Suffolk Council for Racial Equality, and also the Ipswich and East Suffolk CCG. So my role really is to engage with our BAME community to ensure their voices are heard at an official level regarding health inequalities. So now I'd like to introduce you to our panel of speakers. So Ezra, if you could introduce yourself.
Thank you, Siobhan. I'm Ezra Hewing. I'm Head of Education at Suffolk Mind, and I oversee the application of our particular approach to thinking about mental health throughout our services and with partner organisations as well. I'll share a bit more of that shortly.
Thank you, Ezra. And if I can go to Vivek.
Hi everyone, my name is Dr. Vivek Agarwal. I'm a consultant psychiatrist. I work in a community team in Ipswich, which is part of the Norfolk and Suffolk Foundation Trust.
Thank you, Vivek. And Dan, if we can go to you.
Thanks, Siobhan. Hi everyone, I'm Dan. I'm the volunteer run leader at Run Talk Run Ipswich, a peer-to-peer mental health support group. And I'm very grateful for the opportunity to come and speak to you this evening.
Thank you, Dan. And Jason, if we could go to you.
Thanks, Siobhan. Hi, I'm Jay Joseph. I'm as Siobhan rightly said, a transformation lead in Suffolk and North East Essex CCGs, or known as the ICS, and I design mental health projects and services for Suffolk. What I've been doing lately is devising a set of projects to support BAME communities over 65s and people with a serious mental health need.
Brilliant. Okay, thank you guys. Thank you to our panel. So first up, I would like to introduce Ezra Hewing from Suffolk Mind. And again, if you have any questions, please feel free to pop them in the Q&A. Okay, Ezra, over to you.
Thank you very much, Siobhan. Yeah, as Siobhan says, do pop questions in the Q&A and I'll pick them up after in say 10 minutes time or so when I finish sharing what I have to share with you. So if you have interacted with Suffolk Minds before, you may know that we have a particular way of thinking about mental health that informs our services and also the work that we do with partner agencies. And rather than focusing on diagnostic labels, our starting point for thinking about mental health is an idea that mental health professionals and others refer to as the mental health continuum. And it sees mental health as existing along a continuum or a spectrum or a line that runs from a state of well-being at one end to severe mental ill health at the other, and the symptoms of mental health conditions kind of spanning that line or spectrum. And there are a few insights that come about from thinking about mental health in that way. The first is that we're all on that mental health continuum. The second is that mental health is fluid and dynamic. So while diagnostic labels may be very fixed and rigid, and you have to have meet a certain number of criteria to receive that diagnosis, humans are actually, their mental health fluctuates and varies from day to day. And the final major insight is that stress is the crossover point. So it's entirely possible for a person to have a diagnosis of a condition like schizophrenia, but for them to be relatively stress-free and to be managing the symptoms of that condition and to have functional lives. Now, the other really important point to make is that stress is not random. Stress is the result of key physical or emotional needs not being met in a person's life. And if you've attended a course perhaps like Suffolk's Needs Met, we go into great detail and depth on that. I'm not going to do that today, but I am going to give you a kind of a brief summary of those needs, and then look at what the barriers a person may experience in meeting those needs, particularly if they come from a minority ethnic background. So to do that, I'm going to share slides with you. Now, there are different formulations for needs. So if you've come across Maslow, that kind of a thing, you'll be familiar with this idea. We don't think of them as a hierarchy at Suffolk Mind. We emphasize the importance of all physical and emotional needs. So they include physical needs for food and drink, movement to be physically active. Of course, we can use food and drink to try and compensate when we're stressed. We can also use movement to be more physically active, to reduce stress levels and release endorphins, feel-good chemicals and what have you. Sleep is both a physical and an emotional need. We need deep sleep to repair the body, and dream sleep, REM sleep, where dreaming occurs, to discharge emotional arousal. But the more stressed we are, the more we'll dream and the less deep sleep we'll get, and that will have consequences on physical inflammation and what have you. Our emotional needs include the need to feel safe, the need for security, to have control over our lives, to share attention, to feel that we have a status that's recognized by others, that we're valued by others in the wider community, and to be connected to the community and not isolated, to have privacy, downtime to reflect and think away from life's demands, to have an emotional connection where we feel accepted for who we are and that we can trust people, to feel that we're achieving things in our lives, and to feel that we have a meaning and purpose that comes from being needed by others, from learning, and from being connected to something bigger than ourselves. If any of these needs are unmet, we'll experience a degree of stress. If that's prolonged distress, it will push us down the mental health continuum, away from a state of well-being and towards the symptoms of mental ill health. So this is well established by, it's not a controversial idea at all. And given that it's the case, what might be the barriers to meeting those needs that somebody may experience if they are from a minority ethnic community? Well, statistically, it may be that your starting point in life is further down the rungs of the socioeconomic ladder. So you may experience inequality, which is magnified by the pandemic. So immediately our need for financial security may be poorly met. So that can be a cause of stress. That may be something that we feel that we have very little control over our lives. We may really have no control over it. It may be a barrier to us achieving a status in life, perhaps if, particularly if we're at a younger stage in life when the need for status is more pronounced, establishing ourselves in life and in wider society. It may be a barrier to us achieving things, both academically or, gaining an education or employment in life. If we're living in cramped living conditions or inadequate housing, then that can be a barrier to meeting the need for privacy as well, having private time and space perhaps to study, or just time to get away from life's demands and what have you. We may find it more difficult to study, to learn, to get ourselves into a position in life where we feel that we have meaning and purpose. So immediately there are barriers to meeting those needs. We know that first and second generation migrants are more at risk of severe mental ill health, so conditions which may have psychotic components like hallucinations, delusions, and the difficulty with finding motivation or appearing to be very emotionally flat, and the risk is increased for second generation migrants. It's thought that some of the barriers to that may be things like connecting to the wider community, again trying to secure a status that's recognized by others, feeling devalued, and being on the receiving end of discrimination and stigma. Again, the difficulties of juggling cultural expectations, but the risk factors for mental health go up the more a person's ethnic characteristics identify them as other than the host community. living in built-up urban environments, which statistically people from Black and Asian minority ethnic backgrounds are more likely to be living in urban environments. Urbanicity is also a risk factor for mental ill health, and again meeting needs. So if they're living in areas where perhaps they feel unsafe, again confined to communities or even isolated from the wider community, finding it difficult to seek opportunities to share attention in healthy ways for others, or feeling devalued and stigmatized, again those are barriers to meeting emotional needs. What about if a person is seeking help? Well, it may be that when they're seeking help from their GP or wider mental health system services, that those existing disadvantages that we've already outlined may not be recognised by the person that they're working with. So that's another significant barrier. It could be as well that a person is less likely to seek help earlier on, particularly if they've witnessed or experienced family members having negative or traumatic experiences of interacting with mental health systems. We know that statistically people from Black and Asian minority ethnic backgrounds are less likely to receive help from primary care services, from their GP, for example, are more likely to for the symptoms of their mental ill health not to get picked up or not to receive support until they're engaging with secondary care services and their symptoms have become more serious, more distressing, more aggravated. They may also not receive help or engage with services until such time as they, if they come into contact with the justice system, and it may even be that the symptoms of their mental ill health are criminalised, and that's where it first gets picked up, or contribute to them becoming targeted by county lines, that kind of a thing. What could we do to more meaningfully address unmet needs, considering all of those risk factors? Well, we could ask the question, do mental health systems, first of all, recognise emotional needs and the barriers to meeting them? We know that there have been recent advances and improvements in thinking about addressing emotional needs from the point of view of social prescribing. So rather than medicalizing mental health problems, looking at the person's wider life, looking at whether they're socially isolated, do they have opportunities to take part in activities that would connect them up to the wider community, give them opportunities to share attention, to share hobbies and skills that help them meet needs for achievement, meaning and purpose, and give them a greater degree of control over their life. We still have an over-reliance on medication. That's across mental health systems in the UK for sure, but we know that that's an issue in Suffolk as well. And the medical model approach doesn't always take into consideration the whole person, nor does it necessarily recognise and draw upon cultural knowledge and language. And I want to kind of share a couple of examples, opportunities where I've had to learn about the advantages of drawing upon cultural knowledge and language, and unpack what that might mean for people in ways that might better enable them to meet those emotional needs. So just to kind of unpack a little bit more about that, and draw on a couple of personal experiences. So what I mean by the medical model is a way of seeing mental health that relies upon diagnostic labels, and using a language that people who are not familiar with GP services or the medical model may not understand. So that can act as a barrier in itself. People may not know what's meant by a diagnostic label like schizophrenia or borderline personality disorder or bipolar or an anxiety disorder like obsessive compulsive disorder. That language in itself may present a barrier to involving the person in having discussions about how they can address emotional needs and what really works for them, what helps them to manage distress, what are their concerns around things like interacting with the wider community, seeking employment, addressing housing and accommodation concerns, that kind of thing. And a danger as well that we impose a view of mental health that is weird, by which I mean Western, educated, industrialized, rich and democratic, are not necessarily, which is a very kind of narrow view of the world that doesn't accommodate or recognize that people coming from diverse backgrounds, or perhaps whose parents migrated from other parts of the world, may see things in very different terms. I had the privilege, in all senses of the word, of being invited by an Ipswich charity, Phoebe, to visit Zimbabwe a couple of years ago, and to deliver mental health training, and was asked the question. The questioner said, this is great, but we're working with people who view words like depression and other mental health labels as the white man's disease, as something that's been imposed upon them, and they don't necessarily understand mental health in the same way. What should we do? And I said, well, actually, I happen to agree with you. I do think that there's a sense in which it's a Western construct, it's a white man's disease, and that it's much more helpful to focus on physical and emotional needs instead. And in a moment, I'm going to share some evidence with you that needs is not just the idea of physical and emotional needs is not a Western construct, and is a helpful way of thinking about mental health to bypass some of those barriers. A first example, though, comes from some work that we did a few years ago that started with Ipswich Mosque, where they'd approached us about coming up with a way of introducing information about mental health that could inform the people using the mosque should they wish to have a conversation with their GP. And it evolved and morphed into a project called the Quran and Emotional Health, an introduction. So it's a booklet that we also shared with National Mind and was developed further, as is often the case with some of the projects we do. They kind of start here and people forget about them, but they morph and grow in other geographical locations. So the booklet drew upon the practice, Islamic practice, as a way of meeting key emotional needs. So rather than taking the mental health system as its starting point, it took what is knowledge and cultural knowledge from the Quran and from Hadith, traditional sayings attributed to the Prophet Muhammad, as its starting point. And really from that project, we learned that what a culture is knowledge of how to meet emotional needs. So the knowledge that we could be using in our mental health systems already exists, but there's a need to recognize and learn how to do that, and really do some listening around co-production to draw upon that cultural knowledge in ways which better help people to meet emotional needs, reduce stress and distress, and support their mental health. And that involved what's now called BSc Multicultural Services, an Ipswich-based organisation that do fantastic work, and also 9 local minds scattered across England and Wales who work within Muslim communities. And it has been translated into Urdu and Arabic. It also, about 18 months ago, or whenever it was, a couple of years ago, we received a request from the New Zealand government to make it available to people that had been affected by the terrorist attacks at mosques in New Zealand as well. So there you are. I mentioned the work with Phoebe. Following the question that I was asked on my first day at a psychiatric hospital in Harare, I went back to my Airbnb hosts and asked them if they could help me translate the language of emotional needs into Shona, and I didn't know at the time whether this would be possible, and discovered that in a language which is 4,000, 5,000 years old and that migrated from Ethiopia southwards, that the language of emotional needs is universal, and we've since found it in other languages too. In Shona, they talk about meaning and purpose, but they call it Chinangwa, your aim in life. Kubudurero means to rise above the clouds, to meet the need for achievement. And you can see there Ubuntu, which some of you may be familiar with because we use it as a term for computer operating systems, but it means community. And so this knowledge already existed in that language. And once I'd done that, I was able to take it out to a wider community, to mental health training that I was doing with a translator. And you can see there a group of women who are part of a community who fled domestic violence. Many of them are HIV positive. And so stress from unmet needs is a potential killer, because stress will inhibit your immune system and means that people there who are HIV positive are at risk of transitioning to AIDS more quickly because their immune system is impaired by stress. And they knew immediately what I meant by needs without, I didn't have to use medical model language at all. They were able to identify barriers to meeting needs for themselves, but also ways in which they could work together collaboratively to plan how to get needs. And you may be able to see in the background there are some kind of white pieces of flip chart paper stuck to the wall, which was the kind of gathered community knowledge about how to meet needs and how they were going to kind of plan drawing upon that for themselves. So I will pause there to see whether any questions have come up in the Q&A. And I can see that I think there are some already. I'm just waiting for those to load up. And the first question is, what is being done to help people? This is from Kerry at Healthwatch. What is being done to help people, to help staff with the language they use when they talk to people from an ethnic minority? I ask, as a recent staff survey on the subject threw up the fact that many staff do not know what terms to use when talking to people. I think that means people from BME communities. This is not your general equality and diversity training, but, oh, the question's disappeared, hold on. But co-produced training that will make staff much more capable of using language that people understand, making them more approachable and more likely to talk. I mean, you've heard what I've had to say, so I would advocate, of course, being slightly biased, being from Suffolk Mind, that we talk about emotional needs, because I think it's a more inclusive way of going about doing things, and it's possible to translate that into languages that into people's first languages, should they be more recent, have arrived in the UK more recently and still be learning English, or English as their second language. That would be my answer to that question. I haven't received any other questions from anybody at the moment, so I don't know whether any of the other panelists want to join me on answering that particular question, or to ask questions themselves of me based on what I've just spoken about.
Ezra, I'm more than happy to jump in on the question around staff training. So just to remind, I'm Jay Joseph from Suffolk and North East Essex CCGs. We've got as part of our transformation programmes with Norfolk and Suffolk Foundation Trust and with our colleagues across the Alliance, so West Suffolk Hospital, Suffolk County Council and Ipswich and East Suffolk Hospital, we are looking at a suite of cultural awareness training. I think it's been quite hard to source the right kind of thing. I think Kerry very clearly says this isn't about equality and diversity. This is around actually having awareness of the cultures and the different diverse communities in our communities and how we speak to them. I think we'd be keen, looking at our training programs, we can't source nationally the right sort of training to talk to some local communities and to see what we could do to develop something. I think it's really important, and it's a real gap if we've got people working on the front line who aren't feeling confident to speak to people and understand how they speak to people, to be able to one, offer the support they need, but two, to understand where they're coming from. So I think that's definitely something we can pick up and think about a bit more. I know from when I worked at the County Council, we did some unconscious bias training, which was fantastic to understand actually where people form their views and how they think about how they need to speak to people. So we'd really appreciate, I think, and be able to incorporate some cultural awareness training in what we've got is a huge training program over the next couple of years.
I'd really second the idea of involving local agencies like BSC, Multicultural Services, in co-producing training which is relevant for local communities. I think that it's not necessarily a given that something that's nationally recognised will be applicable to the specific challenges of working with a diverse location, particularly like Ipswich and wider Suffolk as well. We've got another question that's come in, which was, how would you encourage mental health discussions with young people from BME communities?
This is the start, so we thank Siobhan for putting this together. So people who've heard about what we're missing, the conversations we're having with community leaders. I know we're doing a lot of good work, so I think of people like Cad Taylor on Norwich Road, doing some great engagement around Norwich Road with young people from BME community. So we need to do more. My area is adults, and we have different commissioners for children and families. But as I refer back to that, we have set up some funding, and Ezra mentioned Phoebe, who are one of the people that we're looking to support, who are going to do some work with young people, young families and mothers, to support those sort of conversation and encourage people to talk more. But I think it's about being open about this and to put it in a way that is acceptable and understandable from people's perspectives. I think the challenge we have is we're quite wordy and quite, as Ezra leads to, quite clinical in how we speak to people, and actually putting in words that people understand and relating to issues they're feeling on the ground is what we need to do more of. So we'll talk to Siobhan and Ezra and our community, voluntary sector communities, and see what else we could be doing to support that. But I would add that schools are doing a great job in talking to young people. We've got some fantastic work working at schools at the moment. There's been a real change, I think, in the way that we approach people who have got complex needs, especially young people. And I feel like we're at a point where people are much more open about talking about where they are. I think we need to expand that to ensure that all our communities feel open to do that.
If you do have more questions for Ezra, please do keep putting them into the Q&A box, and he will endeavour to answer them as the event goes along. So next, I would like to introduce you to Dr. Vivek from the Suffolk and Norfolk Foundation Trust. So over to you, Vivek.
First of all, actually, I know Ezra was running out of time, and there was a question which I found quite fascinating about engaging young people. And immediately I thought, what would I do? What would I have to do to encourage my son to do anything? He's one of the young people of this generation. And I thought the best way to reach him would be if there was a TikTok video that had information about mental health and encouraging people. I think they are voracious consumers of social media, and I think that would be one of the ideas that I think could be employed in terms of reaching the younger generation. But yeah, going back to Ezra's talk, I think you've laid a sort of good grounding for some of the things I'm going to say. Ezra's actually already touched upon a few of the things that will be part of my talk as well. I'll try and see if I can expand on any of that. Before moving forward, I just wanted to clarify one thing which sometimes gets slightly mixed up in conversations, which is the medical model. And I often find that the general view of what people describe as the medical model actually becomes quite confined to diagnosis and medication. And I just wanted to reassure everyone that the medical model is not simply diagnosis and medication. It does include a biopsychosocial view of the person, including cultural aspects as well. And in fact, just like everything else we do, a medical model is also evolving, and the medical model 50 years ago would have been different to the medical model today. We have incorporated a lot of people's psychological, social sort of attributes into understanding of illness and management of illness. And that's not just simply about mental health, to be honest, because nowadays even cardiologists and pain medicine specialists are including research that looks into the social determinants of the illness and the prognosis of those conditions. So moving on, much of what I have got today comes, some of the data is taken from NHS Digital, and then there is this report from Race Equality Foundation, which was quite a good piece of work. It summarizes a lot of the current evidence in terms of racial disparities in mental health. So I guess starting from the beginning, there is quite a lot of research and evidence which suggests that the minority ethnic communities in the UK, and similar thing is found in other countries as well, that we are at higher risk of mental health problems. The minorities also suffer from more social detriments in their lifespan, and the impact of these is greater in terms of their mental health morbidity. It has been found, and this is a figure that's quite widely known and repeated. People from Afro-Caribbean communities 3 times more likely to be diagnosed and admitted with a diagnosis of schizophrenia. Even though the surprising thing is, even though if you look at population research, schizophrenia prevalence in general is found to be quite consistent across populations all over the world. Still, when it comes to minority population, seems to happen a bit more often. Then there's other communities. Irish travelers are 6 times more likely to die as a result of suicide. Sorry. When it comes to access to mental health services, and this is something that Ezra also mentioned about how people from ethnic minorities end up actually getting criminalized for mental ill health. And this is again backed up by a lot of research where it has been found that people from Black and minority ethnic communities are less likely to seek help and less likely to seek help when illnesses are less severe. There are cultural factors to it. There's shame and stigma involved. There's lack of information, lack of knowledge, and then it ends up becoming a crisis more often in these communities. So simple problems that could have been managed at an earlier stage tend to then get left until it reaches a crisis. And again, one of the outcomes, one of the consequences of it is some of these people end up getting picked up through some sort of criminal justice mechanism, and that is why we see that people from Black and minority ethnic populations are 40% more likely to access access mental services via criminal justice. So initially, rather than getting help from health services, they are picked up by police, and then it's recognized that they have got an underlying mental health condition. This is a comparison. So if I don't know if the numbers at the bottom are clear enough, but so there's like if you look at it, the widest horizontal bar is the Black or Black British group, and the numbers at the bottom are out of 100,000. So out of 100,000 in the year 2018-19, what was the rate of detention under the Mental Health Act in various ethnic groups? And as you can see, the rates of detention in Black and Black British was between 250 to 300, so somewhere around 280, I would say 275 to 80, whereas in the same duration for the white ethnic population, it was around 70-75. So as we were talking earlier, the 3 times. So it tends to be this one looks like it was almost 4 times. The rate of mental health detention was 4 times that of the white population. Now, one thing to highlight here is, first of all, prevalence rates, recognition rates of mental illness are higher, but then when it comes to coercive treatment, coercive sort of practice, the rates among minority ethnic communities are even higher. Same picture, hardly, if you look compare between these two, there's hardly any difference. It's still quite prevalent, and despite this information being known since, at least it has been highlighted within the last 2 decades repeatedly. When I was training, this is back in the year 2006, 2007, one of my colleagues was doing a bit of research looking at the use of seclusion and restraint and the differences, racial differences between the use of seclusion and restraint, and found that higher rates of restraint was being used. And it has been recognized, it has been understood, but somehow there doesn't seem to have been a reasonable solution that has managed to address it effectively so far. So what are the reasons why our Black and minority ethnic communities are not able to get the same level of access to mental health care? Why is there a slight bit of misunderstanding around mental health? And again, maybe I'm repeating some of the points that Ezra made, but if you look at this, most of them seem quite obvious. There's lack of knowledge sometimes, different cultural attitudes, and it's quite important to understand the cultural attitudes, because when you look at populations which are 2nd, 3rd generation, they may have better access to knowledge, better understanding of the society and the culture, but 1st generation migrants, sometimes even sort of younger 2nd generation migrants, their cultural attitudes have been shaped in a very different environment. Their ideas about mental health could be very different from what we have, what the Western understanding is, and sometimes that can have a significant impact on their willingness to access healthcare, their confidence to access healthcare. Relationships, again, how much they feel that they are supported by healthcare organizations within their area. And I think to some extent, the Black and minority ethnic communities are slightly, as I said, they lack confidence, but they're slightly fearful of institutional attitudes. There is often, because of the way things are highlighted, whether it's in the media, whether they have had personal experiences, there can be a slight bit of paranoia towards institutions, and it is up to the institutions, up to the big organizations to make sure that people do not have this negative sort of attitude or fear of accessing care for themselves. Now, what has worked is really organizations like Suffolk Mind, voluntary organizations, community organizations, ISCRE, another example. I think these are organizations that can be much more powerful in promoting mental health awareness, promoting the utility or encouraging people to access help as early as possible, especially when dealing with diverse communities. Now, it's not only the prevalence and access to mental health care, but even within mental health services, unfortunately, there seems to be a bit of discrepancy in terms of how people are treated. So if somebody from Black and minority ethnic population is seen within mental health services, often there is a bit of a perception of what the underlying mechanism may be. There is a bit of bias when it comes to treating ethnic populations. And I think, again, it's important that we are, within mental health services, we are aware that these biases, unconscious biases, exist, and they may be shaping our conclusions of assessments of people from different ethnic backgrounds. Treatment and recovery, it has been found, and this was something that I'd not always been aware of, but when I did find out, came to be honest, didn't come as a surprise. I sort of thought that this might be possible, that Black and minority ethnic people are less likely to be referred to talking therapies. And I don't know why. Maybe I'd just not seen as many people from ethnic minorities seeking or in therapy. And it seems that there are figures that sort of suggest that they are, compared to other populations, they're less likely to be referred to talking therapies. As it's quite obvious, I mean, if there are discriminatory experiences within services, they will have a harmful impact on recovery of people. Again, another very interesting point, which was not obvious to me to begin with, I realized, I mean, I have actually been hearing, reading about recovery and the recovery approach within mental health for last several years. And then it turns out that the model that we use for recovery seems to have a very Eurocentric understanding, whereas people from different cultural backgrounds might have different ways in which they look at recovery. And again, I think that is something to be understood, because people have a different way of looking at suffering. People have a very different way of looking at mental distress. And although there are a sort of a narrow range of mental health conditions where there is more clarity in terms of what that how it needs to be identified and how it needs to be treated, for a vast majority of mild, moderate problems, there's so much overlap with psychosocial factors, and similarly so much overlap with cultural and ethnic identity that we need to be mindful of incorporating that within our recovery models. So just to tell you a little bit about NSFT, some of you may be familiar with the Norfolk and Suffolk Foundation Trust, but we provide mental health services within the 2 counties of Norfolk and Suffolk, wide range of services, including for children, working age adults, as well as elderly. There are inpatient units, community services, and we have services based all across, as I said, Norfolk and Suffolk, with the main hubs being Norwich, Ipswich, and Bury St Edmunds. I tried to find out what the trust has been doing regarding race equality, and it seems like within the organization we have a staff network. There's a reverse mentoring program. So the reverse mentoring program works in a way where a junior member of staff from a minority ethnic community might actually allow one of these senior managers to shadow them to see what a working day in their life looks like. There's also a program to ensure that there's more participation of BAME staff on interview panels. We have promoted a staff video in order to encourage people to take the vaccine. The Trust has celebrated various cultural events, including the Black History Month. I must say, as a Black and minority ethnic staff member, I felt quite supported at the time of when the first wave of COVID hit. So I was the consultant in charge on a COVID isolation ward in April last year, and my medical director was quite supportive and asked me if I felt comfortable to do the job and if I felt I was at any additional risk, because at the time there was some research coming out that there was a higher rate of morbidity and death amongst Black and ethnic minority populations. So yeah, there seems to be general support. Plus, when it comes to support for patients, I've worked on wards, I've worked in the community, and generally I've found staff to have understanding of people's diverse cultural needs. Certainly, much more could be done. Certainly, we could have much more awareness, and I think I don't think the equality and diversity training, as it is generally disseminated at the moment, does much to change people's conscious biases, unconscious biases. But I think there are some things. So for example, the things that I really learned a lot from was Awareness Day. So I years ago, I went for a Jewish Awareness Day where I spent kind of almost 3/4 of the day in a synagogue, hearing from the Jewish community about their practices, about their history, and those sorts of things. I think having that kind of more awareness of other diverse groups actually probably may do more to address any unconscious biases. Thank you very much for listening to me. At University of Suffolk, we have started a drive to refer to communities as global majorities. Not just a majority statistically, but in terms of histories, repertoire of knowledge. Yeah, really good point. So paranoia, all the evidence suggests that you have an increased chance of dying under mental health care under section, especially if diagnosed with schizophrenia and are a Black man. That's not paranoia, that's paying attention to published data. And I think that's probably, yeah, it's understandable paranoia. It's not completely unscientific, because when you know of adverse consequences in certain systems, obviously it makes you a bit fearful, it makes you a bit reluctant to access care. And I really hope that we carry on working towards instilling confidence that we do not have such poor systems that we create this kind of huge disparity between people's outcomes in healthcare. Got one from one of my colleagues, Lamia. Thank you, very interesting. Where do people in minority ethnic communities show up? That is, if they show up, the prevalence rate is likely to be significant underestimate. What can we do to address such deeply embedded, and as mentioned? So yeah, I think the question, the issue is quite clear. The issue that there is a huge disparity is quite clear. How do we address these inequalities? I don't think I have a magic solution. It's although some things would be obvious. Education is the most important. Education and awareness are the most important. But there has to be a willingness within the top of the organization to make it a priority. And I think that can happen in several ways. We have got a strong we've got a strong sort of group within NSFT that looks at cultural and diversity issues, but at the same time, I think if the disparity is so significant, as you can see, there needs to be more that has to be done. And as I said, there has to be people at the top. It has to come through policy. It has to come through systems. The changes have to be there has to be political backing for these changes. So I think if the disparities, addressing the disparities is made a priority, there's more chance that we will have some sort of resolution to it. But there may be other panel members who might have thoughts on this, so I'll hand over to anyone else who wants to answer this.
Yeah, it's all right, Kev, if I come in just on that. I think there are some issues, deep-seated issues about, you know, numbers of people from different communities and actually how we approach that. I think one of the things we're trying to do is, as Vivek clearly stated, and Ezra did as well, and I'm sure Dan will come on to as well, it's about getting down to community level and really understanding what's happening at community levels in streets and neighbourhoods, and getting people to talk more openly about what's going on. We've seen a huge change, I think, in the last sort of 10 years or so in the UK about talking about mental health and being much more open about it being on TV programmes and getting people to talk and not to stare at the television. There's been lots of things to try and do that. I think probably what we haven't done as much, and I think this showed in COVID as well, actually, with more diverse communities, we got the message out to, you know, white British people, and then we didn't think about how we translate that message to other people at all. And I think the same can be said in mental health, that we've got a generalist message out to the populace, but what we haven't done is really think about how we convert that information to people who naturally pick that up. So we'll continue to work, and it's a work in progress, continue to work with local community groups. And I think the big thing is getting out to people. So rather than getting people in to come and see us, actually getting out to people, getting out to religious leaders and community leaders and speaking to them. And I don't like the word champions because I think it always sounds really odd and a little bit quaint, but I think actually getting people who can converse, as Ezra said earlier, in a language that people understand, and try and get people to open up about what's needed. I think our communities are brilliant at holding people together, and sometimes the reason we only see people in a crisis because actually their community has held them together for a very long time to the point they can't manage anymore. And I think we just need to get further upstream and actually say to people it's okay to come and ask for some support, or for us to communicate better education and tools for those communities to support each other. So there's work to do on that, but we've done pockets of it. We just need to do a lot more.
Thank you, Vivek, and thank you, Jason, as well. Again, please, I encourage you to keep publishing into the Q&A. But now I'd really love to welcome Dan from Run Talk Run Ipswich. And Dan is down in the community doing work with people. So please welcome Dan.
Good evening, everyone. Thank you for inviting me. And I'd like to say there's been some really good foundations laid by Ezra and Vivek around our emotional needs not being met, and hopefully I'm here to kind of, like Siobhan said, I'm in the community, and hopefully I'm here to help meet those needs, or at least signpost to meeting those needs. Mental health is a cause I love. I can talk about that for hours and hours, and I've been passionate about helping others since my own recovery, due to having nowhere else to, I just had nowhere else to turn, and I did attempt suicide on more than one occasion, but I'm still here to do this presentation now, so that's obviously a good thing. I've supported through mental health charities through Movember, Miles for Mind, Lost Hours, Calm Walk, and also in my full-time employment, I'm a mental health first aider. I decided to set up Run Talk Run after following this wonderful community on social media, after reading a Small Runners World article and seeing how much it was helping others, and it made sense for me to combine my passion for helping others, a love for getting outdoors, come rain or shine, and I just couldn't help but think, let's have some of that for Ipswich. It might even help my own recovery, and boy, has it done that. So Run Talk Run, what are we? We're a weekly running or walking meetup, because we're also not just Run Talk Run, we also are Walk Talk Walk. We are always free. We are a safe and confidential space to talk about mental health. We believe in forming friendships and a community, We believe we're here as a place to listen to others and also feel heard ourselves. We always listen but don't advise, and will always be a gentle run or walk that is open to all abilities and all backgrounds. What we aren't is a competitive environment. We're not group therapy. We're not a place where you have to be fast enough, chatty enough, or confident enough. You just come as you are. And we definitely aren't therapists or fitness coaches. If you do have them qualifications, of course that's a benefit, but we're not here for them gains. Obviously, I'm here representing Run Tuck Run Ipswich. However, I also, after my second or third week of leading Run Tuck Run Ipswich, our founder Jess reached out for support in branching out into regions, because the demand for Run Tuck Run and Walk Tuck Walk was so high on her as a single entity. So I became the East of England regional volunteer. So if you know anyone in these areas, you could obviously signpost them, or if you can access these areas, get there. But yeah, today we've got Run Tuck Run Ipswich, Run Tuck Run Baldock, Run Tuck Run Norwich, Peterborough, Bury, Southend-on-Sea, and we have 2 Walk Tuck Walks in Basildon. Hopefully coming soon, we have a Run Tuck Run in Cambridge, Little Canfield, possibly Dereham, and a Walk Tuck Walk in Dereham too, a Walk Tuck Walk in Waterbeach, and it's still got Basildon on there, but that one is now fully set up, the second one. So enough about what it is. Excuse the cat. Let's get involved. We use an app called My Crew. So all you really need is a smartphone to get involved. That's how you would book onto a run or walk near you. All the volunteers have an admin status to set up their own run or walk and message their participants. And we're also using it for track and trace in these in the current climate. We're all over social media, both Run Tuck Run, Walk Tuck Walk, and our founder Jess, Facebook, Instagram, LinkedIn. Not yet on TikTok, Vivek. But you know, you've inspired me there. And you might find individual meetups like my Run Tuck Run Ipswich have a local account, not just the main site. If you're thinking, oh wow, I could even set one of these up myself, or what I would like to do is get out more in the community as our East of England regional leader, and set up more runs and meet communities that want to do a dedicated one. We have a really mixed group at the down at the Ipswich waterfront, predominantly female. Even most recently on Saturday, I met someone who said I can only run 2.5 kilometers in one go. And I'm really slow. She came to this week's Sunday session and she ran a full 5k at around 6-minute kilometer pace, no stops, with the group all together. And it's just so brilliant that we're doing that. Yeah, if you're thinking about setting your own one up, you register your interest on our main webpage, runtuckrun.com, where we've also got a policy statement. And yeah, if that's the main place to really signpost, if you're thinking, oh, someone could definitely benefit from Run Tuck Run, go to the main website. So, yeah, signposting. We have a big demand really for people setting up Run Tuck Runs and Walk Tuck Runs, and also getting new runners and walkers along. So please do signpost to us. Please do think, oh wow, you know, this is a great community activity. Let's get more people going. Yeah, shout them along. And a big one for me is partnerships. Someone asked about young people. Unfortunately, I have been turned down by University of Suffolk to go and do a talk there, or even get posters up, because they only display their own approved content. And I've also reached out to the University of East Anglia as well. I've had no reply from them, but I want to help people, as you can tell, and they've got to let me in really, and tell them about Run Tuck Run and Walk Tuck Walk, just like I'm here today. But cult cafe where we meet and we can drop our stuff off and we can get changed and we can use the facilities. Cult Cafe are the best partnership I've ever formed. We've got no obligation to buy anything. They've just supported me from day one since starting Run Talk Run. And also I've become, Run Talk Run Ipswich has become a compassionate friend of St Elizabeth Hospice to support their Dying Matters community and the compassionate communities campaigns that are going on at the moment. So we welcome anyone to come to Run Talk Run and have a conversation about death as well as mental health if they need to. Feedback on the right hand side. As I read these bullets out, hopefully you should see some animations. If you want to have us just a brief read of just some of the feedback we've had from attendees at Run Talk Run. This first one is very powerful. I've already shared you with this week's female runner who ran nearly her first 5k on her own, well, as the group. But yeah, it's attacking loneliness, it's giving them structure to their week. We're making new friends. We've got regulars now. We've also got new people that just come for one session, miss session, come back because they've almost made a friendship. It's giving people confidence. Yeah, it's giving people that headspace, and a few people might have heard this presentation before or me talk about it. Cult give us brownies at the end of the run. So we're meeting a lot of emotional needs. We're getting endorphins from the run. We're in it as a community, running together, and we're getting chocolate brownies at the end. What better way could you celebrate your first Run Talk Run or Walk Talk Walk? Thanks for listening. I'm happy to answer any questions. And I'll just keep flicking through these. I just like looking at them when I'm reminding myself of what we're doing in the community. Yeah, that's all from me. Thank you. Happy to answer any questions. Like I said, please do get involved.
If I could come in, I think it's a fantastic idea, Dan, and it's great, and it's exactly what we're talking about: local communities, local people in the communities doing things to keep themselves well and support one another. So fantastic initiative. And I think, as probably Siobhan says, how do we link it to more things? I think it's great to be able to promote it today. If you need any help with promoting with other VCS organisations, I'm more than happy to, if you take some contact details and put you in front of some people. I was thinking maybe some of our older people groups at Active Lives do some stuff around healthy walking and running. So I just think it's these things that keep people well and give them road to recovery, and they're simple things and they're person-centered things. So yeah, just fantastic, really. So thank you ever so much for starting up and keeping it going.
Yeah, Dan, that's fabulous. Great to hear about the work that you're doing. Last week and this week, there's a keep moving Suffolk campaign that's launched. Have you seen it? All right. So I would encourage people to visit that. I'm sure that, Dan, you're pushing people in that direction too. Definitely. And it teaches people how they can meet emotional needs through being physically active. And there's a lot of stuff on there about the relationship between physical inflammation, excessive REM sleep, and depression, and how you can address that through just gently increasing physical activity, how you can motivate yourself and get together, meet needs for community and so on, in exactly the way that Dan's described. So fabulous.
Yeah, can I also add, I think, Dan, you'll be pleased to know that I spend more time talking to my patients about increasing their physical activity than I spend talking to them about medication. So absolutely, I think it is so much more important in terms of overall well-being. My message usually is to all my patients: increasing physical activity, it will help your physical health, it will boost your confidence, but it has real changes, it creates real changes in the brain, because running and cardio exercise actually releases enzymes in the brain that improve the connectivity. So no doubt it's a fantastic thing to do.
And if you combine that with a new friendships and let's say it is your first 5k, that first achievement of doing it, it's just, it's a game changer, really. And I'll just pick up on the support for setting up a new group question. There's loads of support. If you were in the east of England, I'd be doing all your onboarding, and you can probably tell from my passion, I wouldn't let anyone kind of not get the help they need. And Jess herself, the founder, if you regular emails from her, monthly webinar, like monthly Zooms and webinars, all of the graphic design, Canva stuff is all available. You get loads of support in setting one up. And if you're already in an area like Ipswich, you know, I would happily encourage collaboration and someone coming to run lead with me and you know, run some sessions. That's not a problem as well. So.
Hi Dan, so there's a couple of questions for you in the Q&A box. So we have one from me. So are the BAME social prescribing team aware of the work that you guys are doing? I don't know. Like Shira and
I haven't spoke to them myself, so I'd say for now no, but I definitely think we should engage in that conversation and go from there. Yeah.
Fantastic. So I can give you the details of that down.
Thank you.
To date. So you've already answered the question about setting up. They would love to have you over for a talk, seminar, lecture, Dan. So would you be able to share your email inbox?
Yeah, I will do that. I'll share my email now. Yeah.
Great, and amazing initiative. Well done. Looking at the moderator's question about social prescribing team being aware of your group, including faith and community reps.
Yeah, so like I said, I've reached out to the UOS and UEA to obviously encourage the younger people from 18 plus. But yeah, I'm happy to engage with any community leaders and faith reps to help more runners come along from any background. We're just a community of runners that want to talk about our mental health and put the world to rights in that 30 minutes run we do.
Fantastic. And I've got a question from Kerry at Health Watch. Would really like to be in touch about this, Dan. I would strongly recommend this to my good neighbourhood scheme network across Suffolk. Many serve rural communities, so this would be a great thing for that.
Sounds perfect. Yeah, I'm happy to share. I'll share all my details in this chat shortly.
Brilliant. Okay, so I want to thank you all, and especially thank all our speakers today for the fantastic and informative presentations. I think it's been a great success, so thank you. And again, for our attendees, thank you so much for attending and giving your time to listen to these initiatives that we have within our area. The next one that we will be holding will be next month, and I'll be looking at LGBTQ within our minority ethnic communities. So thank you so much for attending, and enjoy the rest of your evening, and hopefully we'll see you again next month. Thank you.